Hello, everyone. We're glad to have you join us at another one of our surgical lecture series. This is Rasha Kakati. I'm a Med4 student at AUB, and I'm the logistics coordinator at the Association of Women Surgeons Lebanon chapter and the Women in Surgery Interest Group Lebanon chapter as well. Today, we'll be kickstarting a wonderful twist on the various surgical subspecialties. We'll be tackling essential must-know aspects in the emergency setting, as we'd like to provide a well-rounded foundation, basically, for surgery and surgical subspecialties. It's an honor to introduce our speaker for today, who is Dr. Zeina Korban. Dr. Korban is an otorhinolaryngologist specialized in rhinology and endoscopic base of skull surgeries. She also frequently collaborates with multiple neurosurgeons. She completed her residency in ENT surgery at AUBMC and then went on to complete a fellowship in rhinology at the University of Miami in the US. She's also the director for the Otorhinolaryngology Clerkship for Med4 students at AUB. It's important to note that Dr. Korban has been a huge supporter and enthusiast of the Women in Surgery Interest Group since our launch, and we're very grateful for her uplifting energy and encouragement. So today we'll be going over a must-know topic in ENT surgery and medicine in general. This is a topic every medical provider should be familiar with and perfect. So before we begin, I'd like to remind you all to keep your microphones muted and to specify any questions that you might have in the chat box. We'll be going over them towards the end of the session during a Q&A slot. So at this point, I'll leave the rest for Dr. Kurban.
Hi, thank you very much, Asha. First of all, I'd like to thank the Women in Surgery Group for having me as their speaker and to include me as part of your lecture series. It's really a pleasure, and I'm a great supporter, and I truly believe that you have something great here, and keep it going. So today, we're going to be talking about airway management in emergency setting. Emergency airway management is a central part of emergency medicine, and the first priority whenever a patient walks into an emergency setting is to try to secure the airway. And this can be very challenging, especially when you're faced with situations where there is upper airway obstruction. So in order for you to achieve rapid and successful intubation, you need to understand the current evidence and updated evidence on emergency airway management. First pass success is very important because failed first intubation attempts usually are associated with a higher risk of adverse events and higher risk of failure rates and a prolonged time to achieve return of spontaneous circulation, which can lead to serious adverse events such as hypoxemia and the various neurological outcomes and MIs. So encountering a patient with a difficult upper airway can be very stressful. And the fate of the patient really depends on how trained we are in the evaluation and the management of the airway. And some causes of airway obstruction are very evident and obvious as soon as the patient comes into the ER, but there are many difficult airway situations that can manifest at the induction of anesthesia, and you're left with very little time to manage. And if you don't recognize them, your patient can deteriorate really fast, and you're left with a very life-threatening emergency. So what is the difficult airway? Airway, we don't really have a universally accepted definition. However, it can be encountered up to 27% of the time. And usually to categorize a patient as a difficult airway patient, you need to have one of the following criteria: difficult bag mask ventilation, incomplete laryngoscopic visualization, difficult intubation with standard airway equipment, and a difficult cricothyroidotomy. So when we talk about difficult ventilation, it's the inability to deliver the necessary tidal volume via face mask, even when you're using an oral or a nasal airway. When we talk about difficult laryngoscopy, it's the inability to visualize the true chords despite external laryngeal repositioning. And when we say this patient basically is going to fall under the category of difficult intubation, it's when you've performed a difficult laryngoscopy, you've attempted intubation more than 3 times, you've even attempted intubation with non-standard equipment and approaches, and inability to intubate using any kind of available method. Then this patient falls under a difficult airway patient. So in order for us to address and manage a patient with a difficult airway, it's very important to establish a team approach. Usually otolaryngologists, anesthesiologists, ER physicians, and hospital staff are involved. Otolaryngologists are not usually the first responders, but we're usually involved whenever a patient falls under a difficult airway and intubation was attempted and failed. So this team needs to establish a management algorithm because inability to obtain and maintain an airway can be a very high risk factor for mortality. And a difficult airway is not just encountered in the ER, but also in the OR, and this can be seen in up to 4% of the cases. So why is it important to establish what a difficult airway is? Because if we don't, hypoxia can result. And hypoxia can occur because of excessive number of failed attempts by different operators. You're attempting with the same device over and over again. There's inadequate oxygenation between attempts. The patient aspirates the gastric contents during face mask ventilation. And because of multiple attempts, you may have traumatic edema of the larynx. So an airway management algorithm was proposed. Several algorithms were proposed actually, but the universal airway algorithm is the one that most of us follow. And the reason it's proposed is for rapid decision-making in order for physicians to reduce errors and improve the quality of management. And one of the most important part of this algorithm basically is to be able to identify the difficult airway, to achieve first pass success and avoid the scenario of the can't intubate, can't ventilate scenario. So So the universal airway algorithm goes as follows. So whenever a patient comes to you, to the ER, you need to understand that most of them are not cooperative. So if they're unconscious, they're unreactive, they're near death, you go to the crash airway algorithm. If that fails, you go to the failed airway algorithm. We're going to be looking at these in a few slides. If the patient is not unconscious, is not unreactive or near death, you need to establish and evaluate whether this patient has a difficult airway or not. If they do, then you go for the difficult airway algorithm. And if that fails, then you go for the failed airway algorithm. If they don't have a difficult airway, then you proceed with rapid sequence intubation. So how do you evaluate a patient for a difficult airway? So adults with impaired airway can present with dyspnea, stridor, whether inspiratory, expiratory, or biphasic, voice changes, hemoptysis, odynophagia, dysphagia, and cough. And the causes can vary from infection to malignancy and to trauma. So you need to look for neck and facial masses, scars, maxillary position, mandibular position, pharyngeal structures, the neck mobility. Try to look for these on the spot once the patient walks in. However, most of us and what most otolaryngologists rely on is the flexible fiber optic laryngoscopy because it helps us evaluate the upper airway all the way from the nose down to the larynx. So there are some alarming anomalies and abnormalities that may tell you that you are going to be dealing with a difficult airway, such as patients who present with anatomically upper airway anomalies. In the pediatric population, you may be dealing with a lot of syndromic patients that have Pierre-Robin syndrome or Klippel-Feil syndrome. And whenever you encounter a patient that has these syndromes, then you should be alert and expect that you may be dealing with a difficult airway. Patients who have decreased cervical mobility because of rheumatoid arthritis or ankylosing spondylitis. Patients who have underwent previous neck surgeries. Patients with acromegaly because this can lead to thickening of the jaw and soft tissue structures of the face. Patients who have epiglottitis, tumors, or any other anatomic upper airway anomalies. So the mnemonic that we like to use is called the Bones mnemonic. And usually the Bones mnemonic looks at the following characteristics in patients. And if the patients have 2 or more of these characteristics, then you anticipate difficult ventilation. So the B stands for bearded, the O for obese, the N for no teeth, elderly, more than 55, although I don't think that's really elderly, but still, snorers and sleep apnea. So what is difficult laryngoscopy? What else do we look at? So difficult laryngoscopy is the degree of glottic view with the laryngoscope. The most widely used system to categorize this degree of visualization of the larynx is the Cormack and Lehane grade. So, and this grade ranges from 1 to 4. 1 means complete visualization of the glottis, and you can see the vocal cords completely and the posterior commissure. 2 is partial visualization of the cords and the posterior commissure. 3 is a visualization of the tip of the epiglottis, and grade 4 is no exposure at all. And grade 3 and 4 are usually correlated with difficult or failed intubation. And you need to try to predict before you attempt intubation what kind of Cormack-Lehane grade you are going to encounter. Other predictors is the interincisor distance. And usually this should be more than 3 fingers. And if it's less, then that may be associated with difficult laryngoscopy. Also the thyromental distance. The thyromental distance is also known as Patil's test. It's basically a distance between the tip of the thyroid cartilage, as you can see in the image here, to the tip of the chin. And the neck is usually fully extended and the mouth is fully closed. If it's more than 6.5 centimeters, then you're good. There's no issue with intubation or laryngoscopy. If it's less than 6 centimeters, then your laryngoscopy may be very difficult. Hyomental distance is another prognostic factor that we look at, which is the distance between the mentum and the hyoid bone. When it's less than 4 centimeters, you know you will be dealing with difficult intubation and difficult laryngoscopy. So then your patient will fall under a difficult airway algorithm. Sternomental distance is another test that we perform, also known as the SAVA test. It's basically the distance from the upper border of the manubrium to the tip of the mentum. And this is also performed with the neck extended and the mouth closed. And the minimum acceptable value is 12.5 centimeters. And this actually is a very good predictor, and it's the single best predictor of difficult laryngoscopy because it has a high sensitivity and specificity. So in a nutshell, basically, if you want to summarize all of these tests, this is the 3-3-2 rule that you should always keep in mind. It's basically, you have to have at least 3 fingers in the mouth, 3 fingers from the mentum to the hyoid, and 2 fingers from the floor of the mouth to the tip of the thyroid cartilage, as you can see in the image here. So whenever a patient doesn't fall under the 3-3-2 rule, then this patient, you may be dealing with a difficult airway. Mandibular protrusion is something else that we look at, and it falls under 3 classes. Class A is where the lower incisors can be protruded anterior to the upper incisors. Class B is where the lower incisors can be brought edge to edge with the upper incisors. And Class C, where there's significant retrognathia. And Class B and C are associated with difficult laryngoscopy. The Mallampati classification is something that you've all probably heard of. It's what the anesthesiologists basically rely on prior to surgery and prior to elective surgeries, actually. And the only disadvantage of the Mallampati classification in an emergency setting is that most of the time your patients may not be cooperative enough because this test needs to be done in the neutral position. The patient needs to have maximum tongue protrusion. They need to be in the sitting position. So it may be very difficult for you to assess the Mallampati grade and class. Class 1 is complete visualization of the tonsils, the uvula, the tonsillar pillars, and the soft palate. Class 2 is where you only see the upper tonsillar folds and the anterior tonsillar pillars. Class 3 is the soft palate is only visible, and Class 4 is where only the hard palate is visible. And Class 3 and 4 is associated with difficult intubation and difficult laryngoscopy. Other predictors is when patients present with the neck in the flexed position and where they've had a history of extreme head and neck radiation changes that can cause significant scarring, and also the presence of large masses that can distort the laryngeal airway and the anatomy of the larynx as well. Other predictors is the increased age, the male gender, having obstructive sleep apnea, having a high BMI, the absence of dentition, and having an underlying chronic obstructive pulmonary disease. What about children? So usually dealing with children with a difficult airway can be very stressful, especially in an emergency setting. And some indications would be having a child present with previous surgeries or intubations, children who have congenital anomalies, history of foreign body aspiration, and during physical exam, patients with a difficult airway can present with nasal flaring, accessory muscle use, stridor, and voice changes. And stridor, especially inspiratory stridor, can be a sign of upper airway obstruction. So there's a lot of anatomic differences between children and adults, and that starts off with the location of the larynx, where it's higher up at the level of C4 in children versus C6 in adults. They have an increased airway collapsibility, which may contribute to easy obstruction in children and a lot of redundancy. They have a larger relative tongue size. They have less developed accessory muscles and decreased pulmonary reserve. So any change, even a very small change in the radius of the airway, can cause a significant dramatic airway compromise and decrease in airway patency. Other predictors would be a child who presents to you with a small mouth aperture. The hyomental distance is extremely important in the pediatric population. And here it would signify a difficult airway if it was less than 1.5 centimeters in newborns and infants and less than 3 centimeters in adults and children. Also dealing with syndromic patients such as Korban, Down syndrome, golden heart, patients who have micrognathia, retrognathia, macroglossia, supralaryngeal pathologies, and glottic pathologies such as the endoscopic view that you see here, where you have a laryngeal web that formed anteriorly that can completely narrow the glottic area and can contribute to difficult intubation. Predictors of difficult laryngoscopy. So how do we predict difficult laryngoscopy? What do we do? So usually ED patients come to you unable to follow commands, especially those that require airway management. And melampathy can only be measured in 30% of those patients. So there's a mnemonic that helps us predict whether we're going to encounter difficult laryngoscopy or not, and that's the lemon mnemonic. The M stands for melampathy, and there's a new modified classification now that basically removes the melampathy classification. And this lemon mnemonic is concise, and the absence of any of the items can indicate the absence of difficult laryngoscopy. So this is basically the lemon mnemonic. So L is looking externally at the patient for characteristics that are known to cause difficult laryngoscopy, intubation, or ventilation. E, the 332 rule that we talked about, which is the interincisor distance, at least 3 fingers, the hyodental distance, 3 fingers, and thyroid to floor of mouth distance, which is 2 fingers. The melampathy, which we can exclude. Obstruction, which is any condition that can cause an obstruction of the airway and which makes the laryngoscopy and ventilation difficult, such as epiglottitis, tumors, abscesses, trauma. And N is for neck mobility. Imaging. How does imaging play a role in an emergency setting when dealing with the airway? So, of course, imaging can be helpful. However, sometimes we're faced with not enough time in order for us to know what's going on. Chest X-ray can be helpful, especially in patients who have, in pediatric patients with foreign body aspiration or larger airway obstructions. CT and MRI extremely crucial to identify structural causes. For example, the axial CT cut that you see here, you can notice that there's a parapharyngeal mass that's obstructing the airway. But for us as otolaryngologists, the flexible fiber optic laryngoscopy is the best way to assess for airway patency because we can evaluate the airway all the way down to the larynx and make sure that there's going to be no issues if we have enough time actually to assess the airway. So the history and physical exam in an emergency setting is usually taken simultaneously because you need to immediately secure the airway. And whenever a patient has stridor, because acute stridor can be brought about by any kind of respiratory illness, you need to have a systematic approach. And as we've mentioned, a flexible fiber optic laryngoscopy is the best and immediate way to assist in order to evaluate the airway. So when a patient presents with stridor, there's a very important mnemonic that you should follow in order for you to know when to intervene and what to do. And that's the SPECS mnemonic. S stands for the severity and of the obstruction. P is the progression of the symptoms. E is whether there's any eating difficulties or history of aspiration. C is the presence of cyanotic episodes, whether there's any obstruction during sleep. And R is for any kind of radiology or imaging that was performed. So what kind of equipment do you need in an emergency setting to deal with the airway? So every OR and ER is equipped with an airway management cart that's always filled up at the end of the day, and the location has to be readily available. And you have to have an airway management cart for adults and one for pediatric patients. It should include rigid laryngoscopes of multiple sizes. It should have straight and curved blades. You need to have ET tubes of various sizes as well, CO2 detectors, stylets or bougies, tracheal introducers, and glidoscopes, which is known as video laryngoscopy. In addition, we have to have McGill forceps, laryngeal masked airways, which we call as extraglottic devices, and that's the ET tube that you see here with the balloon rim. You need to have both nasal airways and oral airways, various face masks, a light source, and a tracheotomy set that has to always be there on standby in order for a surgical airway if a surgical airway is needed. So in order to be ready and to be prepared, there's a stop mnemonic that helps you remember all the tools and the different steps that you may need in an emergency setting. S stands for suction, so you need to always have suction readily available. You need to have all the tools that are there for intubation, the blade and the handle, oxygen, adequate positioning, monitors, including pulse ox, blood pressure monitor, and esophageal detector sometimes. A, you need to have adequate assistance, ambo bags, different airway devices, different ET tube sizes. I, an IV access, and D, all the different drugs that may be needed for rapid sequence intubation and induction. So management is extremely important. And always remember, anything that can go wrong will actually go wrong. So you need to master your algorithms. You need to know what you're dealing with. You need to be able to evaluate difficult airways in order for you to secure the airway quick and fast. Pre-oxygenation plays an important role. because desat and hypoxemia during intubation can lead to serious complication and unfavorable neurological outcomes. So pre-oxygenation extends the duration of that safe apnea phase in order to prevent hypoxemia while you're intubating. And the way you pre-oxygenate is usually with tidal volume breathing for 3 minutes. And oxygen sources without pressure support, such as face masks with bag valve masks, as you can see in the image here, and just regular nasal cannulas can be used. Face mask with the bag valve mask can give you 60 to 70% FiO2 at a flow rate of 15 liters per minute. And in patients with adequate spontaneous ventilation, it is not necessary to squeeze the bag, but ensure that you have a tight mask seal to deliver high FiO2. So if inadequate spontaneous ventilation is present, then you just give a little bit of positive pressure with the bag valve mask. However, if the patient is spontaneously ventilating, you don't need to squeeze the bag. And in the ICU setting, patients receiving ventilation with the bag valve mask in the interval between induction and laryngoscopy have lower rates of hypoxemia than those, have higher oxygen saturations and lower rates of hypoxemia than those with no ventilation. So what is apneic oxygenation? It's where you're basically delivering oxygen using a nasal cannula to the nasopharynx while you're intubating to maintain oxygenation. And this can reduce hypoxemia during intubation and improve first pass success in the ED and is usually advised. Proper positioning is extremely important in the before intubating. Although intubation is attempted in the supine position, there are some studies that suggest that elevating the head to a more upright position between 20 to 45 degrees can improve pre-oxygenation, first pass success, and decrease intubation-related adverse effects. So what are the different ventilation methods that we talk about? Non-invasive ventilation basically refers to positive pressure ventilation without having to intubate your patient, without tracheal intubation or ET tube intubation. So there's no, it's basically using a BiPAP or a CPAP and should be considered when sufficient oxygenation can be achieved. And there's no contraindication to it, such as you cannot use this in patients who have an altered mental status or respiratory arrest. And what pre-oxygenating with non-invasive ventilation does is that it increases expiratory lung volumes due to alveolar recruitment from the positive airway pressure and helps with pre-oxygenation. And the rate of severe hypoxemia is lower in non-invasive ventilation that's delivered by face mask compared to patients who just receive bag valve mask ventilation in patients with respiratory distress. Another way where you can provide non-invasive ventilation is the high-flow nasal cannula. This is different from using the nasal cannulas nasal cannulas that are not delivered with a high flow, because what the high-flow nasal cannula does is that it gives you humidified gas flow mixtures. So you have a higher FiO2 than with standard oxygen, and you're maintaining oxygenation during the apneic phase of intubation. However, this is a relatively recent development, and the benefit for pre-oxygenation still remains slightly controversial. Mask ventilation, essential element of airway management anywhere in the ED, on the floors, in the OR, and it's used before intubation and also as a rescue during unsuccessful attempted intubation. So if you've attempted intubation and you failed, you always need to go back to mask ventilation before you attempt again. However, it does not protect you from aspiration, and it does not allow high pressures to be delivered. And another thing is that with bag valve mask ventilation and mask ventilation, you can force air into the esophagus, which can impair respiration even further. The mask ventilation can be very difficult in bearded patients, and what might help is inserting a nasal airway or an oral airway in order to help with the mask ventilation, especially when you have cases of soft tissue collapse in the upper airway. And if mask ventilation is difficult, do not administer any paralytic agents. So what are the different intubation methods that we have? So usually we talk about rapid sequence versus non-rapid sequence intubation. Rapid sequence is basically intubating with medications and sedatives, and non-RSI is basically without using medications. Before doing this, you need to consider all factors, whether you have enough equipment, rescue devices that are present, the different pharmacological agents, and the staffing. RSI is usually the standard in any emergency airways. However, that's without an anticipated difficult airway. Things change when you're dealing with a difficult airway. When you use RSI, you're giving sedatives plus neuromuscular blockades. And it shows a higher success rates and lower adverse effects, but this is in patients who do not have a difficult airway. So what we do is that we use pre-medications such as fentanyl, neuromuscular blockades such as succinyl choline and rocuronium in order to improve glottic visualization and immobilization. And also it helps protect patients from tachycardia, from gagging, coughing during intubation. It also provides them with sedation and amnesia, which can help. When do you give the pre-medication before you intubate? Usually it's given at least 3 minutes prior to intubation, but that's in an elective setting. In critical cases, you can give it less, even before the 3 minutes, or you can omit it entirely. Lidocaine is used for reducing bronchospasm. Fentanyl is used to reduce the sympathetic response. And atropine is not used as a pre-medication, but should always be available in case bradycardia occurs. Sedatives are usually given to provide for analgesia and amnesic properties, and usually what we give is either etomidate, ketamine, midazolam, and propofol. The advantage of using midazolam is that it can be given for long-term sedation. Propofol, you should be very careful by using it because it can cause cardiovascular depression and lead to hypotension. The neuromuscular blockades that we use are succinyl choline and rocuronium. Be very careful with succinyl choline, especially in patients who present with musculoskeletal injuries, spinal cord injuries, or renal failure, and it's usually contraindicated in those patients. Rocuronium has been increasingly used, and it has a very good advantage in that we can rapidly reverse it. It has minimal adverse effects and a broader eligibility. So this table really looks at the different medications that we use in the emergency department. And you can see that most of the medications are lidocaine and fentanyl as pre-medications, etomidate, ketamine, midas, propofol, as discussed. So what about when you're dealing with a difficult airway? Non-rapid sequence intubation is the appropriate choice in patients who have a difficult airway. When the patient is ready for intubation, perform your standard laryngoscopy. If you see the airway, just intubate the patient. However, let's say you don't see the airway. What do? You move the patient to something called a modified Jackson position, which is basically placing a pillow under the head of the patient, 10 to 15, which elevates the head 10 to 15 centimeters. So then you end up having two axes, the oral axis and a pharyngeal axis, that will coincide and will improve glottic visualization. Other things that you may do that may help you initially before resorting to other measures is external laryngeal pressure. External laryngeal pressure is not cricoid pressure. They are two different things. External laryngeal pressure, also known as the burp maneuver, is where you're pushing on the larynx, as you can see in the image, backward, upward, and rightward. And this helps improve the laryngoscopic view. Cricoid pressure is different. Cricoid pressure is also known as Sellick's maneuver. And what the cricoid pressure does is that it pushes the cricoid from anterior to posterior and compresses the esophagus because you're pushing the trachea posteriorly. And what cricoid pressure does is that it helps in preventing aspiration of gastric contents. So there are various intubation methods. So you're in the ER, you've performed your standard laryngoscopy and you have failed. So what do? You move on to larger laryngoscopes. You try to resort to different approaches, such as using McGill forceps or stylets. However, what's advised is to start off with video laryngoscopy. And actually, video laryngoscopy is superior in the ED and can have better visualization, higher first pass success, shorter time to intubation. And it's very important in patients who present with trauma, difficult airways. And the video laryngoscopy, what you probably know as the glidoscope. And it usually causes a lower force to oral structures and less soft tissue injury. So if we look at the advantages and disadvantages of the video laryngoscopy versus the regular direct laryngoscopy, the advantages is that what we've talked about, which is it's a faster time to give you a better intubation. It's improved laryngeal view. It permits others to share the view. So it's very important because this helps facilitate intubations, lower risk of soft tissue injury. And also it's very useful for teaching and training, which is also very important. Is very important in any airway management. The disadvantage, however, is that you need to have trained physicians, and it requires different skills. And sometimes the vision can be obscured by fogging secretions or blood. And also it's very expensive and it's very difficult sometimes to obtain and purchase video laryngoscopes. So you've tried your first intubation, you failed. You've tried 3 times and you failed. So what do? You stop. Because repeated laryngoscopy can cause laryngeal bleeding, edema, increase secretions, and eventually you can't ventilate, and you end up with the cannot intubate, cannot ventilate scenario. You have to resort to alternative approaches, and those alternative approaches include something we call extraglottic devices. The bougie, also known as the tracheal introducer, can be elastic, or it can be like a stylet made out of steel. And usually the elastic bougies are recommended. And what they do is that they're useful in helping to facilitate intubation in patients with laryngoscopic views. And then when the bougie is used, it's generally in combination with rapid sequence intubation and can be used in conjunction with video laryngoscopy, standard laryngoscopy, or fiber optic intubation. So it's very beneficial when you can see the epiglottis, but not the vocal cords. So what you do is that, as you can see in this image, you can introduce the tracheal tube and insert it over the bougie. So the bougie really acts as a guide. And the recent randomized control study found that using a bougie results in significantly higher first-pass success rate among patients undergoing emergency airway management. And sometimes it's used from the get-go. So if you are anticipating that you are dealing with a difficult airway, and we're going to see this in the algorithm, then you should start off by trying to use your extraglottic devices initially, after attempting video laryngoscopy. What about awake fiber optic intubation? Awake fiber optic intubation is also something that we can do. However, the patient needs to be awake and needs to be cooperative. And this is the next choice in a difficult airway. And this is where otolaryngologists are consulted and are on standby, because sometimes awake fiber optic intubation may fail and you may be dealing with upper airway obstruction, and we end up having to resort to a surgical airway. So the ET tube is going to be inserted either through the nose or through the oral cavity into the airway of an awake and cooperative patient. So the mandible and the tongue are pulled anteriorly so that you expose the larynx. You apply either oral airway or a nasal airway with topical anesthesia. And this serves as a visual guide and a stylet to ensure the tube is placed over the carina. So you go all the way, even when you pass the cords, you just make sure that the position of the ET tube is right above the carina. It's safe in patients who have a difficult airway, such as those with trauma or masses, but it's very important that the patient is cooperative and awake. LMAs, laryngeal masked airways, are excellent, and they're really excellent extraglottic devices. They provide effective oxygenation and ventilation without having even to enter the trachea. And they can be used as transitional devices until a definitive airway is established and when intubation can't be achieved and the patient has a difficult airway. What's nice about it is that it's balloon rimmed, so it gives this uniform pressure onto the valleculae, the hypopharynx, the piriform sinuses, and the retrocricoid area, and it will seal the GI from the airway. So when you're sealing the GI from the airway, you're protecting from any kind of aspiration that should occur. And also you're preventing air to go into the, you're preventing air going into the esophagus, which can further elevate the diaphragm and contribute to respiratory distress. So laryngeal masked airways can be resorted as a rescue method when you're dealing with a can't ventilate, can't intubate scenario before you proceed to a tracheotomy. The combi tube, I'm sure most of you have heard about it. The combi tube is a double lumen airway. It's an esophageal tracheal airway. It's a blind insertion airway device, which you can see in this image, which is used in emergency setting as an extraglottic device. It's equipped with a pharyngeal balloon and a distal cuff. And it's designed for blind insertion into the patient's esophagus or trachea. So you have two different lumens. The pharyngeal lumen is inflated with 100 mLs of air, and this seals against the oral cavity, while the distal cuff, the tracheoesophageal lumen, basically is going to be inserted with up to 15 ml of air to prevent gastric inflation. However, there are contraindications for the use of the combi tube, and those are basically any kind of esophageal pathology, any caustic injury, or central airway pathologies. And the disadvantage is that you can't really perform any pulmonary toileting or suctioning of tracheal secretions. However, an advantage is that it protects against aspiration of gastric contents, similar to the laryngeal masked airway, and the applicability of high airway pressures. And it can stay in place for up to 8 hours, so it gives you enough time for you to decide on what kind of step you want to take next. What's the difference between the combi tube and the laryngeal masked airway? When properly positioned, the combi tube allows ventilation with a higher seal pressure than the classic LMA. It protects against regurg, and it allows a subsequent attempt at fiber optic intubation while keeping it in place and while the inflated esophageal cuff maintains airway protection. That's the advantage of the combi tube. Intubators is basically the physicians that are involved, and those are the main players in any kind of emergency airway. The International Anesthesia Consensus recommends using different approaches such as, and that includes using different intubators and experienced intubators for subsequent attempts after a failed first attempt, because someone who's experienced is likely to intubate more successfully. So usually second intubation attempts by the same physician compared by a second attempt by a different physician usually gives you a lower success rate. So rescue intubation by emergency physicians or senior physicians is associated with a higher probability of success at the second attempt. So when do we resort to a surgical airway? So this is where otolaryngologists play the crucial role, and that's where usually we are consulted. Surgical intervention is when all modalities are unsuccessful. And a surgical airway should be achieved. Indications for surgical airway includes upper airway obstruction with stridor, bilateral vocal cord paralysis, neck surgery and trauma, air hunger, previous radiation, and the key of a surgical airway is early and extremely rapid access to the trachea. All heard of the emergency cricothyroidotomy. So when we've reached that scenario of can't ventilate, can't intubate, we've resorted to extraglottic devices, we still haven't established an airway, we need to go for a surgical airway. The emergency cricothyroidotomy is a rapid method for securing the airway. And we know that the trach set has to always be by bedside. However, the disadvantage of an emergency cricothyroidotomy is that it needs to be converted to a tracheotomy within 24 to 48 hours. There are, however, contraindications that we need to be kept in mind, and those include any kind of laryngeal trauma or severely fractured laryngeal cartilages. So therefore, you cannot perform a cricothyroidotomy, you need to resort to as an urgent tracheotomy. Any case where you can safely establish ET intubation, so you're not justified to perform an emergency surgical airway. Other contraindications can include infant and toddlers where you prefer jet ventilation, bleeding disorders, massive neck edema, which may make it very difficult, and acute laryngeal disease. To perform an emergency cricothyroidotomy, you need to master the surgical anatomy of the larynx. You need to be able to identify the landmarks. The most crucial landmarks are the sternal notch, the cricoid cartilage, and the thyroid cartilage. The cricoid cartilage is the complete ring. And the cricothyroid membrane is the membrane that stretches between the thyroid and the cricoid cartilage. And the advantage of this space is that it's basically very easily palpable and identifiable between these two structures, and it's fibrous in nature, so it's gonna have minimal vasculature, and you're gonna encounter minimal bleeding. So how do we perform this technique? How do we start off? So basically, we start off by palpating the landmarks, identify the cricoid notch, the cricoid cartilage, the sternal notch, and the thyroid cartilage. Then feel the cricothyroid membrane in between. A vertical incision is always done in an emergency setting to minimize bleeding. So a vertical incision is made starting off from the area of the thyroid cartilage down to the cricoid cartilage. You dissect the skin, and then the dissection is performed through the skin and subcutaneous tissue. And then the cricothyroid membrane is identified. However, a horizontal incision is made through the cricothyroid membrane. You may use a hook to elevate the cartilage to provide greater exposure, and you insert an ET tube through this cricothyroid membrane. Any kind of bleeding is left, you ignore it, and you just make sure that you're establishing the airway. What's the emergent awake tracheotomy or the slash tracheotomy? Emergent awake tracheotomy is what most otolaryngologists resort to. So we know that it's uncommon for us to be the first responders. However, usually when we're there, we tend to go for the tracheotomy versus the cricothyroidotomy, and that's because we always face the short and long-term complications of these procedures. And emergency cricothyroidotomy is associated with a higher risk of subglottic stenosis, accidental decannulation. So for us, the tracheotomy is safer and more effective in an emergency surgical airway. It's reliable and it's life-saving. There's different types of tracheotomy. We talk about the slash tracheotomy, which is done in the emergency setting when the patient is in respiratory arrest. And this is associated with a very high complication rate, up to 21%. We talk about the urgent awake tracheotomy, which is done in the OR under local anesthesia, where the patient is in respiratory distress. However, this patient is stable enough to be taken down to the OR. We talk about elective trachs, where the patient's already intubated or in the ICU, where the incisions completely change, and percutaneous trach, which is usually performed by the pulmonary service by bedside. How do we perform an emergency awake tracheotomy? So patient will ideally be placed in a semi-recumbent position. A shoulder roll is placed to allow for extension in order for you to be able to identify your landmarks. So similar to a cricothyroidotomy, identify your sternal notch, cricoid cartilage, tracheal thyroid cartilage, and start off by identifying the cricoid cartilage, and then start with a vertical incision. And this is extremely important because this is what differentiates a slash tracheotomy from an elective tracheotomy. So usually in slash tracheotomies, we perform a vertical incision versus in elective tracheotomies, a horizontal incision is made. So we start the vertical incision at the level of the cricoid cartilage and we extend it. And if the surgeon is right-handed, the left hand is used to stabilize the larynx while the right hand holds the scalpel. Sometimes it's just one physician doing this. The incision is made through the skin, platysma, subcutaneous tissues in one swift motion. You may not encounter the straps and the thyroid isthmus during this maneuver. And even if there's any kind of bleeding that's encountered, you have to ignore it because the main concern here is to secure the airway. Once you've identified the second or third tracheal ring or estimated where your second or third tracheal ring is, a vertical incision is also performed through the trachea and an ET tube is inserted. Sometimes a tracheal dilator may be used. And any kind of bleeding is ignored until the airway is established. And once the airway is established, then you can control the bleeding with Surgicel, or you can even, if the situation permits, take the patient down to OR, revise the tracheotomy, control the bleeding, revise the incisions. But usually in an emergency setting, you need to be quick and fast. That's why we call it a slash trach, because it's just one swift motion. So the difference between a cricothyroidotomy and a tracheotomy is that some guidelines state that the cricothyrotomy is preferable. Most of the otolaryngology guidelines tell you that a trach is preferred because complications from a cric are more frequent and severe. And you may have more injuries to cartilaginous structures and a higher rate of incorrect execution versus the complications after trach that can range only up to 5%. So in this image, what you can see is an accidental entry into the thyrohyoid membrane instead of the cricothyroid membrane. So, and this patient underwent accidental decannulation as well. So instead of going through the cricothyroid membrane, they went through the thyrohyoid membrane. Next image shows you an endoscopic view basically of an ET tube going through the thyrohyoid membrane as well, right above. And this can cause significant laryngeal trauma and laryngeal edema, and it can cause difficulties after surgery. So the cricothyrotomy versus tracheotomy, what's important to remember is that even if you perform a cricothyrotomy, conversion from a cric to a trach is necessary within 72 hours. And this can cause a higher hospital stay, neurological impairment, death. So cricothyrotomy is preferable for non-surgical physicians versus surgeons who prefer a trach. And it's very safe and it's an effective means of securing the airway. And also remember that it depends on surgeon experience and patient characteristics. So if you don't have anyone available to perform a slash tracheotomy, then go for the emergency cricothyrotomy. Go for any kind of approach that is needed in order to secure the airway. Complications of trach can range from immediate, early to late. Usually in the immediate phase, the patient may bleed out. That's why we perform vertical incisions in an emergency setting. They may lose the airway. We may accidentally not be able to identify the tracheal rings. Early on, we may get pneumothorax, pneumomediastinum, subcutaneous emphysema. So usually after performing any kind of trach, we get a chest X-ray post procedure. And the late complication can be tracheoesophageal fistulas, tracheomalacia, and tracheal stenosis as well. As otolaryngologists, the way we deal with upper airway obstruction is we deal by level of obstruction. And the way we divide this is according to anatomy. So we start off with the oral cavity, hypopharynx, moving down to the supraglottic area, glottis, and subglottis. When we talk about oral cavity or the hypopharynx, we sometimes face a lot of cases of masses of the oral airway and oral cavity, trismus, inability for the patient to even open his mouth, abscesses, and anything which can prevent standard intubation and even placement of any kind of airway or even laryngeal masked airways. So tracheotomies may be our safest bet. And sometimes we may be faced with patients such as this CT here, where you can see excessive mandibular fractures that can lead to prolapse of the tongue and immediate loss of the airway. So also we may have to resort to tracheotomies from the get-go. Sometimes we may have swelling or masses above the supraglottic area. and I mean in the supraglottic area, which also will not allow us to get or to intubate the patient or even resort to extraglottic devices. Flexible fiber optic laryngoscopy is extremely helpful in these cases and can reveal difficult intubation, and we also resort to local tracheotomies. Regarding the glottic and zodiac level, flexible fiber optic laryngoscopies and CTs can reveal difficult intubation, and a tracheotomy may be needed. The cervical trachea is also, we can also encounter stenosis from the cervical trachea. Lesions or stenosis below the level of a trach may be very difficult to manage, and sometimes you may need jet ventilators. We consult the cardiothoracic team. We resort to long tracheal tubes and long Shileys as well in order to bypass the level of the obstruction. Special circumstances that you have to always remember is, first of all, trauma, because 10 to 30% of intubation in the emergency department occur due to trauma, and the first pass success rate can go up to 86%. And this can be very challenging because of the urgency, the anatomic distortion, the amount of secretions, the hemodynamic instability that you're faced with, and always assume that these patients have a C-spine injury until proven otherwise. So you may not be able to properly position them for intubation. So then you're faced with difficult intubation. Other special circumstances are dealing with the pediatric population, as we've discussed. Usually in children, the intubator's experience plays a major role in first pass success. Pediatric ER attendings have the highest success rate of up to 89%, much more than pediatric residents and fellows. So even pediatric emergency medicine fellows have a higher success rate. So the major challenges for airway management really in the pediatric population is understanding the anatomy, knowing whether you're dealing with any kind of anomaly, age-related issues, know what kind of tube you're choosing and device, and be able to calculate the appropriate dosage of medications so that you don't find yourself in any kind of adverse event. So another thing to remember in children is that they have a lower functional residual volume, so they can and higher oxygen metabolism, so they can face hypoxia much more quickly than adults. So you need to be very fast, and you need to take your decisions extremely quickly when dealing with children. So always be aware of the difficult airway in children. 9% of children in the pediatric ICU setting have a difficult airway, and that's much higher in the ER as well. And that's because children have large oropharyngeal structures. Sometimes you're faced with kids that have large tonsils, a large tongue, large adenoids. All this can lead to upper airway obstruction. Also, they tend to have larger and floppier epiglottis. They have an omega-shaped epiglottis. They have redundancy and a floppier supraglottic area. And the position of the larynx makes visualization of their vocal cords more difficult. Nowadays, since it's an extremely hot topic, special circumstances need to always address and remember is COVID-19. COVID-19 on its own is basically dealing with the airway. There are many guidelines, and the COVID-19 guidelines recommend that airway interventions should be performed in a negative pressure room in a dedicated area. You need to have the most experienced and skilled person in order to get a first pass success, and they need to be the ones performing the first attempt. Why? Because you need to have the highest chance of success to minimize aerosol contamination and to protect healthcare workers. Tracheal intubation when dealing with COVID-19 patients with respiratory arrest should be limited. After a failed first attempt, you should consider an alternative device or an alternative technique, actually, if a repeat is indicated, because multiple attempts can be associated with airway edema, trauma, and systemic complications, and having to resort to surgical airways that increases the risk of aerosol transmission and puts everyone at risk. The Difficult Airway Society guidelines state that a maximum of 3 attempts at laryngoscopy is recommended, with only a permissible plus 1/4 attempt by a more experienced colleague is usually allowed. The Airway and COVID-19 guidelines also recommend pre-oxygenation in head-up or in a ramped position, and it has to be performed with a very tight-fitting mask. And there's conflicting evidence actually regarding other forms of oxygen therapy, whether a surgical mask should be placed over the patient's mouth and nose, but always the staff should wear appropriate PPE, but always try to get a tight-fitting mask when you're pre-oxygenating a COVID-19 patient. Also, they recommend supraglottic airway ventilation versus other types of ventilation because it forms a better airway seal, has a higher success rate and lower rates of transmission. And if successful, it's reasonable to use this airway as a conduit for flexible bronchoscopic tracheal intubation. And this way, you're sealing the airway and minimizing aerosol transmission. So both types of ventilation are recommended, face mask and supraglottic ventilation, but usually supraglottic ventilation should be resorted to as a rescue ventilation technique after you failed tracheal intubation. What if you're dealing with a COVID patient and you get the cannot intubate, cannot ventilate scenario? What do? Tracheal intubation should be performed in an awake, spontaneously ventilating patient. So you need to resort to a phona procedure no matter what you do. You've tried direct laryngoscopy, you've tried video laryngoscopy, you've resorted to your extraglottic devices, you need to go for a front of neck access, although this is aerosol generating. So usually any kind of intubation in a COVID patient is aerosol generated and should only be performed if indicated. Try to avoid giving sedation, try to avoid airway topicalization because this can cause aerosol contamination and care must be taken to minimize this. And try to avoid giving any kind of positive pressure or high flow oxygen. So basically, if we want to summarize the algorithms and what we've discussed throughout this talk, we start off with the unified airway algorithm. So let's say, for example, that a patient presents, needs intubation. You ask yourself whether they're unresponsive or near death. If yes, you resort to your crash airway, which we will not discuss. If no, we'd ask ourselves, are we dealing with a patient who has a difficult airway or not? If they have difficult airway, we go for the difficult airway algorithm. If not, we proceed to rapid sequence intubation. We administer our pre-medications, our sedatives, our neuromuscular blockades, and we attempt intubation. If we failed 3 intubations, then we resort to our failed airway and difficult airway algorithm. Next, we deal with the difficult airway algorithm. If we can go back just 2 slides, Asha, sorry. The difficult airway algorithm, always call for assistance, always call for help. If you're forced to act and you have no time to know what you're dealing with, just give the rapid sequence intubation drugs and try to attempt intubation. If you failed, then you need to go for the failed airway algorithm. If you're not forced to act, try to maintain oxygenation. If you're not able to maintain oxygenation, then use an extraglottic device or bag mask ventilation. If you're not successful, try to go for an awake technique. If that's not successful, then you need to resort to video laryngoscopy, flexible endoscopy, cricothyroidotomies, and other types of procedures. What about the failed airway algorithm? If you can't maintain oxygenation and extraglottic devices are attempted and they fail, then you need to resort to your surgical airway no matter what you do. When you have a failed airway, choose one of the following: video laryngoscopy, extraglottic devices, stylets, and if that fails, always resort to a surgical airway regardless of what you do, because establishing the airway is key. So key points that you need to always keep in mind: the difficult airway scenarios can occur anywhere, in the ER, in the OR, ICU, even outside hospitals, in procedural units. Remember your ABCs: airway, breathing, circulation. Remember the difference between adult and pediatric airways. Master the anatomy of the larynx. Be able to generate a differential with what you're dealing with. Make sure you have all equipment available and ready to go. Consider all your different management options. Consider all types of supraglottic maneuvers, tracheal intubation, surgical interventions. Follow a systematic approach. Dealing with a difficult airway can be very challenging, and you have to be very ready for a quick intervention, and always call for assistance and call for help. And teamwork really is the best way to address this. Thank you very much. If anybody has any questions, thanks.
Thank you so much, Dr. for this really amazing session. No joke, it was an amazing wrap-up of all of the algorithms, all of the different approaches. I think it's very, very essential to have gone through all of these concepts. And you provided amazing mnemonics, which I think would be super beneficial for everyone. So thanks a lot. And we really appreciate your cooperation with us today, despite the technical difficulties. So in case anyone has any questions, you can go ahead and write them up in the chat box. And let me check. We have one question actually more.
Yep, I just saw it. Why absence of the teeth makes a difficult intubation? So first of all, thank you, Rasha, again. Sorry for the technical difficulties that occurred. I'm so glad that you enjoyed the lecture. So basically, absence of teeth makes it difficult because you're not being able to basically use the laryngoscope with ease. You're not being able to stabilize the laryngoscope. And that makes also everything more floppier, more redundant. And you see it every day in the ER, especially with elderly patients who have dentures, and once they remove their dentures, it makes intubation very difficult. So in pre-op evaluation, what are the main things to evaluate? So usually evaluation occurs at several stages. So first of all, evaluation pre-op, that's pre-op, not an emergency setting. It starts off in our clinic where we evaluate the patient's airway. We always perform on any patient that's going to go to the OR a flexible fiber optic laryngoscopy, because usually we're taking these patients to OR for otolaryngologic purposes. So if we anticipate any kind of upper airway obstruction, we can tell by performing this in clinic. If our FFL is normal, then anesthesiologists also evaluate the patients. They go for the Malampati classification that we looked at. They go for the they go for the different maneuvers, environmental distance, all the different things that we looked at, and basically the different mnemonics we discussed. Why don't we use from the beginning intubations? That's another question. Why don't we use the bougie from the beginning to decrease the number of attempts? Because the bougie actually, and we kind of see it frequently, can cause a lot of mucosal trauma, mucosal lacerations, and can cause injury. And if somebody is attempting to use the bougie and is inexperienced, it can cause significant injury, and sometimes it can cause esophageal perforations, bleeding, obscuring vision even further. So you need to be quite experienced with using the bougie.
All right, thanks a lot, Dr. Korban.
As an answer to everyone who's writing, thank you. You're more than welcome. Thank you for having me.
We're very glad to have had you. Thank you a
I
lot.
think this is an excellent group and excellent organization, and keep it up.
Thank you
Really.
so much. We appreciate it.
You have my full support always.
Thank you. And thanks to all our participants for constantly joining us and supporting us. And I hope you guys all have a great evening or a great day wherever you are.
Thank you. Thanks. Have a good evening.